Today's episode is brought to you by Microsoft Dragon Copilot, your AI assistant for clinical workflow, which helps to ease administrative burdens. We don't like those.
They are the
Those are
worst.
terrible.
There are way too many in healthcare.
Automatically document care, streamline workflow, and just help you build a good patient-physician relationship. That's what it's all about. Learn about how Dragon Copilot can transform the way you work. Visit aka.ms/knock-knock-high. Again, that's aka.ms/knock-knock-high.
Knock, knock, hi.
Welcome, everybody, to Knock Knock Eye with me, your host, Dr. Glaucomflecken. Again, your one-stop shop for all things eyeball related. You guys ready to learn some eyeball stuff? So we got, here's the agenda for today. I'm going to give you a recount of my call week. I'm coming off of another week of call. I have one more night to go. I'm going to try not to jinx it. Last night, I got home late. I had some calls a couple of calls overnight, nothing I had to go in for, but it did disrupt my sleep. So I apologize if I sound a little bit haggard. I feel like I always look the same. My hair's always a mess. If you're watching me on YouTube, but it's, so I might have some word finding difficulties. I'm not what I used to be. I used to be able to, when I was a resident at Iowa, man, we covered such a large area, and as the only level 1 trauma center, we'd get tons of trauma. And so it was pretty common taking primary call at Iowa, because the culture was, no matter what's going on, just come in. We'll see you. We will see you, which was great for learning as a resident. I felt very comfortable dealing with any kind of eye emergency that could come through the door, but it made for some sleepless nights. And it was home call. So I got used to, maybe not sleeping at all, or just kind of getting maybe an hour or two and then powering through clinic the next day. No way could I do that now. I got like maybe 5 hours of sleep last night, and I already feel grumpy. I can't even blame it on low testosterone right now because I just got my replacement. I am tanked up and ready to go, but then like a slightly less than optimal night of sleep, and I feel like I'm just a grumpy old man. Is this what the 40s are like? Is this I don't know how people like do the big hospital call, all of you, and like the specialties that require like busy call, like trauma surgeons. How do you do this for a career? How do you do call for a whole career? I tip my hat to you. If I wore hats, which I don't because my head's too big, I tip my hat to you because it gets harder as you get older. I don't know. Maybe that's why people just stop taking call, or they pay their associates to take call for them. Be like, hey, I've got a call shift coming up. Can I give you $1,000 and you'll do this for me? Yeah, that's a thing that happens. Anyway, I can't really complain about my private practice ophthalmology call. I'll get into a couple of details here in a second. Basically, just give you an idea of like what the week was like, and a couple points about emergency stuff. And then I'm gonna tell you about a cartoon character and their eye problems. I'm gonna do another one. I think you guys liked hearing that. A couple weeks ago, I did an episode. I started doing like Disney characters. I talked about Disney characters and like the eye problems, basically diagnosing Disney characters, or just giving you an idea of their vision assessment. And people like Hector from Coco. Who is it? Goofy with with the Cyclops, the one eye. Anyway, so I got another one for you. And then we're going to do a part 2 in our signs and symptoms series, where I take a symptom, an eyeball symptom, and we go through a differential. I give you an eyeball sign, and then we go through a differential. So that's the rundown for today. All right, so let's go back to call. So in general, I would say on a scale from like 1 to 10, 1 being if you liken a call week to a prison sentence, minimum security. They just leave the gate open, just let you go. Yeah, that's a 1. To maximum security, death row, 10. All right, I would give this one a 3. So it wasn't bad. In fact, I never had to actually go in to see patients for the whole week. I take a week at a call at a time, 3 weeks total. That's the advantage of having a lot of partners, is that you only have to take call once every quarter, basically, or even less than that, honestly. Um, and so I didn't have to go in to the emergency department to see the patients, but I did get a fair amount of phone calls, a couple of them in the middle of the night, which it's fine. That's why I take call. That's why we do it. But a couple things. One, I was very impressed with my emergency medicine colleagues over the course of the week. They did a phenomenal job getting me the information that I needed to be able to triage these patients, figure out when they needed to be seen. There's one still common misconception that I think is still perpetuated in emergency medicine world that I wish we could disabuse people of this notion that any possible retinal detachment is a drop everything pants patient emergency. It really is not the case. So here's a couple examples. So I got a call one night. It was like probably 1 a.m. I got paged, flashes and floaters, pretty convincing story. Yeah, it could be a retinal tear. I told the emergency doctor, I said, okay, send them to this office first thing in the morning. I'll take a look. And turned out to have a retinal tear. Lasered it in clinic. Everything was fine. Another patient it was like 9 p.m. I told again, flashes and floaters, classic, symptoms. And again, with flashes and floaters, that's the biggest thing we're concerned about is that the vitreous, which is that fluid that fills the back of the eye, the gel-like fluid, it pulls off of the retina, causes a tear. Fluid can track underneath that tear and lift up the retina. It's like you're lifting wallpaper off of drywall. You're just kind of pulling it up. And so with retinal tears, retinal detachments, it's common to think, oh, this is like you gotta, with a retinal detachment, you gotta come in and take care of it right away. But no, the standard of care in this situation is within 24 hours. That patient needs to be seen. And I say within 24 hours. And so then the question is, okay, well, what's the cutoff? Like if it's like 2 o'clock in the afternoon, are you going to make him wait a full 24 hours? Well, probably not. No. We'll have the patient come in right away because it's within office hours. We got it. We're there. We have all our equipment. All right. And so I'll probably see that patient within a few hours. But it's okay if for some reason you have to wait 24 hours. So then, you know, so here's the question, well, what about in the evening? What about 7 o'clock? That's still not too late. Like, would you want the patient to come in right away? Maybe you could just take care of it that night. Yeah, you could. That's possible. But when you're talking about specialized surgery, like retina reattachment surgery, it requires specialized equipment, but also people that know how to do that job. And that's when it gets a little bit tricky when you're talking about doing that type of surgery after hours, because you very likely will be doing it with a group of people that have never done that type of surgery. And I'm talking like nurses, scrub techs, knowing what equipment to set up, knowing, the order of operations with how you do that surgery, assisting the surgeon. These are probably going to be all new people that don't normally do that type of surgery. And so and plus, if you're talking middle of the night, well, wouldn't you also want your surgeon to be well rested? I know I would. And so if the data shows that addressing that problem in a 24-hour time frame versus like 2 or 3 hours doesn't change outcomes, then let's get a well-rested surgeon. Let's get staff that know what they're doing, they're probably going to be around during business hours more than likely. And let's schedule that surgery. Let's do it right. Let's do it well. So that's the thinking when it comes to retina, what flashes and floaters, potential retinal tear, retinal detachment. And so, but there's this like perception that this is an emergency. This is one of the true emergencies in ophthalmology, but it's not. It's not a pants patient. I will put my pants on, but we're gonna, within 24 hours, I'll put my pants on. All right. I'd like to be pantsless for a few more hours. That's fine. I want to get a good night's sleep. I'll come in and take a look. Patients, they'll do okay. And honestly, this is something that I was a little bit surprised about whenever as I went through residency, is in talking to retina specialists and working in a retina clinic, in hearing like not in hearing, seeing the how that's not so much of an emergency. Seeing how those surgeons dealt with that type of thing, and they do it in this exact way. About 24 hours is fine. And so anyway, all the patients did well. Other things, but going back to the emergency colleagues, phenomenal job. All of them. Every time I talk, I probably had fielded about 6 or 7 calls over the course of the week from the emergency physicians. Again, I know, not that bad. And always had vision. They always had a good pressure that made sense. Motility. A couple of them even tried to look at the fundus, which I gave them kudos for. It's like, great job. I'm so glad you tried. Don't worry that you didn't see anything. I don't care. It's fine. At least you tried. That's great. And so it just hats off to them. They did a great job all week, and had a lot of patient phone calls too. And but it didn't have to go in. Nothing came in. Knock on wood. Oh God, I still got one more night. I really shouldn't be doing this the night before call ends. I'll update you if something just outrageous comes through the door. I'm trying to think of like probably the worst call cases I've had. I've had lots of major trauma, as I mentioned earlier, over the course of my career. But some serious infections too. Some of those corneal infections, endophthalmitis, where you get an infection in the eye, usually after a patient has had either major trauma or a recent eye surgery. Those can be harrowing experiences. Some patients that have had to be admitted, all kinds of stuff can come in, especially with a group our size. We're the largest practice in the Portland metro area, and so we cover a lot of patients and a handful of hospitals too. So overall, though, 3 out of 10. As far as difficulty, I'd say 8 out of 10, and I would do it again. I would have a call week just like this. I would favor that, especially in the summer. I'm always dreading those call weeks when I have to do one in the summer because things are busy. Right now, things don't, I think the weather, it's cold, it's rainy, keeps people away. All right, let's take a break, and we'll come back with a cartoon character. I got some a diagnosis to discuss. Hey, Kristen.
Yeah.
You know what it's time for?
What?
More Demodex blepharitis talk.
Yay.
We're not talking about mites today, though.
Okay, phew.
All right. I've mentioned the crusties. Remember the crusties? The collarettes?
Yes, I remember
right? It's a
eyelid
telltale
crusties.
sign of Demodex blepharitis. I just want to educate people that you can't always see these things in the mirror. Sometimes you need magnification, the equipment we use in the eye clinic to be able to diagnose this.
So some people might not even realize it when they have Demodex blepharitis?
Exactly. Often patients don't know they have those crusties and can't connect their symptoms of redness, irritation, itchiness to Demodex blepharitis.
That just sounds like allergies.
It can be. It's also a great time right now to make an appointment with your eye doctor before the end of the year when deductibles reset.
Oh, good point.
Yeah. To see more pictures of crusties and eyelids with Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. All right, here we go. The one I've chosen for you all, and I did make a video about this not too long ago, so maybe you've seen this. I want to talk about the Awooga wolf. So this is a cartoon character that has not aged well, but it's from, I had to look this up. It's from the Droopy series. So look up Droopy series. You guys remember this? This is the hound dog that like, he kind of walks real slow. He kind of talks like this. His name is Droopy. I'm doing a terrible impression. But anyway, it's a hound dog named Droopy. If you see it, I guarantee most of you who are over the age of 30 are probably going to have seen this cartoon character before. But anyway, during one of the episodes, there's a very now classic a character of a wolf, uh, 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 and he sees an attractive female character and does the awooga, and the eyes pop out of his head. So let's talk about that. So looking at this, this character, a couple things to consider. First of all, is what are the reasons that this character might have proptosis? Now, there's no sudden onset proptosis uh, can be very serious. Usually, it's just one eye. Essentially unheard of for this to happen emergently like this in two eyes. When you get emergent proptosis out of one eye, it's almost always trauma related. You get a retrobulbar hemorrhage that pushes the eye forward, can cause high eye pressure, stress on the optic nerve, blindness. You have to do a lateral canthotomy. You have to cut the lower eyelid off, sometimes the upper eyelid as well, and to relieve the pressure. There was a great scene about this in um, the Noah Wiley, The Pit. The Pit. There was a good. They did a pretty decent job. A couple problems with it, but overall better than I've ever seen done in any show. And so that's like emergent onset awuga eyes, proptosis. Again, that wouldn't happen in both eyes. One eye is fine. But so what are the other causes of proptosis? And maybe I should back up and say proptosis is when the eyes are bulging forward, right? So they're moving forward, proptosis, the eyes propped up, coming out of the orbit, it looks like. All right, so the most common cause of proptosis in adults is thyroid eye disease. We've talked about thyroid eye disease before, most commonly associated with Graves' disease, which is a form of hyperthyroidism. So you got high thyroid, you got to treat it with either taking the thyroid out, thymazole, and there's other medications that can treat the symptoms of the disease. Sometimes you got to get radiation to get rid of the hyperthyroidism. But that is mostly, I'd say 90, I think it's the stats are like 90 to 95% of thyroid eye disease is found in people with Graves' disease. But you can have hypothyroidism and still have and still have thyroid eye disease. Thyroid eye disease can also be associated with euthyroid, having normal thyroid function tests completely. I don't know if we really know, like that some autoimmune condition is kicking it off, but the vast majority of the time, someone's going to be hyperthyroid. So, so proptosis. So what happens with thyroid eye disease is the muscles that surround the eye. So we're talking the inferior rectus, superior rectus, medial rectus, lateral rectus, your rectus muscles. They get thick and plugged up. Not plugged up. What am I talking about? Thick. I feel like I'm so used to, you know why I said that? I'm so used to talking about meibomian glands. I probably see that like 10 times a day. Your meibomian glands are thick and plugged up. That's the mild sleep deprivation I have going on. So your extraocular muscles get thick. They get large. That's because you have these, proteoglycan, these molecules that are just getting deposited into the muscle, and they just get big and fat. And what happens when you have these big muscles, there's less space in the orbit for those muscles to be able to take up. And so what happens? Well, if there's no space in the orbit, then things start to get pushed out of the orbit forward. And so you end up with proptosis. Now, usually, again, this is unilateral. It can be bilateral or at least asymmetric. And so this is the most common cause of unilateral and bilateral proptosis. This doesn't happen suddenly. In fact, when you have thyroid eye disease, there is a an active phase of this disease that can last several years. We have treatments for this, to help create space in the orbit, which is what's called an orbital decompression, which is a harrowing surgery. It can be very effective, though. You basically create orbital fractures. You break through the walls of the orbit to allow the eye to sink back into the orbit into a normal position. And the reasons you would do that are mostly to protect the optic nerve. Because if you have these thick muscles that are pushing the eye forward, it can compromise. Those muscles itself can put stress, can compress the optic nerve and cause vision loss. Big problem. And so by opening up the orbital bones, by creating little orbital fractures, it creates more space. And so you have less compression and stress on the optic nerve. And it can also be helpful for cosmesis as well. It just looks better. It can be a very difficult disease to have cosmetically, and that's a great reason to want to treat this. And so orbital decompression is one way. That's one way to treat this. Also, just steroids. Often patients will get a course of steroids, either IV or oral steroids, or a combination of the two, to try to decrease the inflammation that can be, causing these muscles to enlarge. There's other antibody treatments that are Tepezza is the most recent one, and people were really excited about Tepezza at first. I think people are cooling off on it because it has some pretty serious side effects. It can cause hearing loss, like irreversible hearing loss. And some of the results are really dramatic with this disease and treating thyroid eye disease. I think some people are a little bit more mixed, but it is still an FDA approved option. So that's your basic breakdown of thyroid eye disease. So the Awuga wolf, I would definitely have this wolf tested for thyroid disease. And definitely go and see an oculoplastic specialist. At least in my practice, in my experience, they're the ones that typically treat thyroid eye disease a lot more because some of those treatments, right, orbital decompression, require orbital work. And they are the ones that are trained in that kind of surgery. That is a very specialized surgery, one I am not accustomed or qualified to provide to people. More power to them, those orbital specialists. So that's the Awuga wolf. Hey, if you guys have like other cartoon characters that you want me to diagnose, I'm happy to. I think people really appreciate that. I don't know why, but I'm happy to do it. It's fun. It's fun, looking at Edna from The Incredibles and how nearsighted she is. And also Professor Farnsworth from Futurama. You guys Futurama fans? I don't know if you are, but I love Futurama. I'm a huge Simpsons Futurama. And Professor Farnsworth has severely thick glasses. The thickest glass I gotta be, if those were real in real life, those lenses would be like a plus 20. That's like legit the Coke bottle glasses that you gave to people back in the day before we had intraocular lenses, artificial lenses. People would have cataracts removed, but we had no lenses to replace them with. And so you end up with these super thick lenses that are like 20 diopter lenses. So diopter being like, so nearsighted, you're like a -2. That's like mildly myopic. Well, a +2 is mildly hyperopic. Imagine a +22 lens. Like that's super, super thick. I think that's what Professor Farnsworth from Futurama has too. That's a little bonus. So I'm happy to do more cartoon characters. Send a message to us. You can email us, knocknockhi@human-content.com, or we have a YouTube channel. Check all the comments there at Glaucomfleckens. Go and leave a comment for me. All right, well, let's take one more break, and we're going to do signs and symptoms. I got more eyeball stuff. Man, look what we've already covered so far. We did flashes and floaters, retinal detachments. We did proptosis, thyroid eye disease. We're going strong still on day 6 of 7 of call. So let's take a break. We'll come right back. All right, let's start with going back to our signs and symptoms series. Oh, that's a mouthful. Triple S, signs and symptoms series. So we'll start with a symptom. How's that? Let's go with one that's a little bit more unusual, but a question that was posed to me in a patient. This is eyelash loss. So again, a symptom is something the patient is experiencing versus a sign, which is something that you, the physician or someone who sees patients, would see on exam that maybe the patient might not necessarily be experiencing. So, symptom, eyelash loss. I hear this from people sometimes. Why am I losing my eyelashes? Or I've lost my eyelashes in this area. And then I ask them further, and they're like, well, I do pick my eyelashes. Like, well, that's a form of trichotillomania. Like, you should just not pull on your eyelashes if you can. Sometimes that's a psychiatric disorder that needs more attention and therapy and treatment for that. But most of the time, it's just kind of a nervous habit for people. They just kind of pull on it. I twirl my hair. That's my nervous habit, and I'm probably creating a blind spot somewhere in the back of my head. Some people kind of pull at their eyelashes. So that is one cause of eyelash loss. So a fancy word for eyelash loss, we call them madarosis. Madarosos, madarosis. And it's just, that's all it means. It's just like an area, either complete or just a small area of eyelash loss. And usually I would say in this context, we're usually talking about just a smaller area. Something like alopecia, forms of alopecia can cause complete eyelash loss. And so that's kind of a slightly different way of describing things. We have a lot of weird, strange words for like related to eyelashes, like poliosis. Well, that's just when you have eyelashes that go white. Yeah, there's some conditions that cause white ocular cutaneous albinism. You can get white eyelashes, poliosis, and forms of. Oh man, I'm blanking on the term where the areas of your skin you lose pigment. Sorry about that. Anyway, that can happen on your eyelashes, and you get poliosis, whitening of your eyelashes. You basically lose that pigment. Anyway, other causes of eyelash loss. Obviously, trauma, burns. So, thermal burns. We see people. I haven't seen a thermal burn in quite a while, but we would see it in Iowa quite often. They would be sent up to the burn unit, and their eyes. Honestly, the surface of the eye is usually fine with a thermal burn because the wave of heat like reaches you before any kind of flames will get at you. And so you instinctually close your eyes and that protects your eyeballs from the flames, but you can still have loss of your eyelashes from the burn, from the flame itself. And so we see that in severe burns. Also, and this is a big one for us in comprehensive ophthalmology, is looking at the eyelid margin. When I say eyelid margin, I mean that's where the eyelid touches the eyeball. Looking for areas of eyelash loss that could be associated with a cutaneous neoplasm. So that is a worrisome sign for an eyelid lesion, is if you have lost the eyelashes directly surrounding that lesion. So if you have like a cyst, you have a sty, that's not going to cause you to lose your eyelashes. You'll have this bump on the eyelid, but there will be the hairs still growing. The follicles are not disrupted. They're still producing eyelashes. But if you have a sebaceous carcinoma, if you have a squamous cell carcinoma, if you have a basal cell carcinoma, you will start to lose the lashes. And so that can be a sign because sometimes they can be a little tricky to diagnose. They can look kind of benign. They don't look real severe. Maybe they're really small. Like, could this be a skin cancer? Well, if you have eyelash loss over that lesion, you really have to consider that and probably want to do a biopsy or just remove it and send it off to the lab. So, cutaneous neoplasm, sebaceous carcinomas, by the way, can be very, very tricky. They can masquerade as just blepharitis. It can be hard to diagnose those. I think I've caught maybe one in my career. I don't know of any I've missed, knock on wood, but you got to kind of have your antenna perked up for sebaceous carcinoma really at all times. Other causes, so radiation. People that have radiation for different things like even choroidal melanoma of the eye, or any kind of head or neck cancer, or you have to have some radiation that can cause eyelash loss. You can obviously, chemotherapy can cause loss of your eyelashes, but honestly, not as often as you'd think. And I'm not sure exactly what the cause of that is, where you have people that lose their hair on their head and their eyebrows maybe, but they maintain their eyelashes. In fact, now that I'm thinking about it, I need to look that up. Um, we talked about chronic skin diseases like alopecia, trichotillomania. So I think that's probably covers it. The big thing of those eyelid cancers. Got to be careful about those. All right, so let's move on to signs. We'll finish off the episode with some ocular signs. What do you want to do? Hyphema, hypopyon, corneal edema, conjunctival swelling. Oh, there's so many ways we could go about this. How about let's do hyphema? What are the causes? What's the differential diagnosis that you see of a hyphema? Now, obviously, people are going to have symptoms related to a hyphema, but the sign of you do the exam and you see that there's a hyphema, that is a sign. And so, what are the common causes of that? Obviously, trauma. Like 9 times out of 10 is going to be trauma, because otherwise, you're talking about more of a spontaneous hyphema. That's much more rare. So, blunt force trauma, that's what's going to cause your hyphema the vast majority of the time. The trauma, it breaks these little vessels you have in the angle of your eye, causes them to bleed. You get this rising level of blood that kind of sits there in the front, in the anterior chamber of your eye. You can see it. Sometimes you can see it with the naked eye if it's a rather large bleed. Sometimes you have to use a slit lamp. You look at it under a microscope and you can see it. I guess iatrogenic is another cause. So intraocular surgery, lasers. I've been doing that kind of surgery for a long time, and sometimes you get a little blood in the eye from the surgery you're doing, whether it's like a glaucoma procedure, and that all goes away. So but that's technically a hyphema, and that would be iatrogenic. So we caused it. The physician, in doing what we do, caused it. Sometimes I'm doing a laser, like a laser peripheral iridotomy. So we do that to release pressure, to treat, to decrease the risk of angle closure glaucoma. And sometimes I accidentally hit a blood vessel, causes a little bit of a bleed. Usually by the next day or the day after, it's totally gone. Clotting disorders are also a possibility for a spontaneous hyphema. Very rare. Honestly, I don't think I've ever seen a patient with hemophilia. And usually when you have that disease, now it's pretty well treated. So I've never come across that. I don't think I've ever seen a spontaneous hyphema for that reason, but they can be pretty severe. I do know that. Just being on anticoagulation, that alone isn't likely going to cause a spontaneous hyphema, but you are more likely to have a hyphema if you're anticoagulated with minimal trauma. So trauma that otherwise might not cause a hyphema, well, you're taking a bunch of warfarin, much more likely to have that bleed that becomes more significant. Herpes is another one. So herpes is famously this disease that can cause lots of problems. You can get inflammation on the surface of the eye. You can get those dendritic lesions, beautiful dendritic lesions. Inflammation inside the eye. You can get atrophy of the iris that can erode through some of those blood vessels and cause a hyphema. So that's one thing there. So herpes simplex, zoster, iridocyclitis. You just get a bunch of inflammation in the eye that causes some bleeding. Intraocular tumors would be the other one. So intraocular tumors, like the most obvious one would be like a melanoma, or even a retinoblastoma in like a little baby. And so these things, they're cancerous lesions, malignant lesions can be more friable, more likely to erode through structures that can disrupt blood vessels and cause bleeding. So if you have a sign of a tumor, a lesion inside the eye, and there's also hyphema, it's a very high likelihood that that's going to be a malignant lesion, or at least something that you need to do surgery to try to remove. Angiomas they're just irregular blood vessels, so they're not malignant, but they can be problematic because they do tend to bleed. And the danger with hyphemas is the risk of developing high pressure glaucoma because of the hyphema. Enough of the eye is filled up with blood that it starts to block off your aqueous drainage system, the trabecular meshwork. So if blood's blocking all of that, then it's like you're plugging a bathtub. The fluid is going to build up, pressure is going to rise, and you're going to damage the optic nerve from high pressure. And so when patients have a hyphema, and I tell this to my emergency colleagues, it's like, what do you got to do? It's the same thing every time with a hyphema. All right. You're going to tell them to be a couch potato. You're going to avoid anticoagulation. You're going to call us. You can call us with a hyphema, and either I'll come in if the pressure's high, or I'll just see the patient the next day and tell you to start prednisolones. That's the other thing we always start as well as an anti-inflammatory, because chances are, with enough trauma to cause a hyphema, there's going to be intraocular inflammation as well. So we want to dial that down. And we also, the last thing with a hyphema is immobilizing the iris with a cyclopentolate anticholinergic medication that prevents the iris from moving in and out, because that's where the broken blood vessels are. So you can imagine an iris that's constantly opening and closing based on the amount of ambient light that's going on. You're more likely to disrupt those blood vessels and cause more bleeding. And the second time a hyphema bleeds, it's always the worst one. That's it. That's your signs and symptoms of eyeballs. Ooh, we did a lot of ophthalmology today. I hope you feel like 10% smarter on your way to being a board-certified ophthalmologist. Because if you didn't know, that's the goal. I'm slowly turning all of you into ophthalmologists. I know some of you are doing other specialties. You've dedicated your careers, but it's okay. You can leave that in the rearview mirror and just look toward your future as a comprehensive ophthalmologist. I don't see anything wrong with that. Thank you all for listening. I'm your host, Will Flannery, also known as Dr. Glaucomflecken. No one knows who Will Flannery is. I have people that hear Will Flannery, they're like, who? What? What is that? Dr. Glaucomflecken. Thanks to my executive producers, Aaron Cordy, Rob Goldman, and Shanti Burke. Our editor and engineer is Jason Pertiza. Our music is by Omer Benzvi. Knock Knock Hi, Knock Knock I is a human content production. We'll see you next week, everyone.
Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.